because, thinking of that heart rate greater than 90, why is their heart rate going up? And then a lot of times you get people on the beta blockers, and they'll have, all of a sudden they'll have this low blood pressure, and their heart rate isn't moving. And they go, well, it's not hypotension, it's just their normal blood pressure because their heart rate's normal. And I'm like, what meds did this person? And then you go in and you look, and they're on beta blockers. And so they're not going to get that heart rate response, but when they came in, their heart rate was 60, and now their heart rate has gone up about 40% from their baseline, and they're sitting only maybe in the upper 80s, and so is that a change for them? I can tell you blood pressure, don't wait. I've been hypertensive. It's a renal issue since I was 14, and you get if my blood pressure gets less than 110, I'm done. So if I had to wait to 90, I'd be in trouble. I had surgery one day, and they go, oh, your pressure's great. It's like 105, and they stood up, and what did Sarah do? She stood right back on the floor, so they're like, well, it should be good. Lactic acid, like I said, measure of tissue hypoxia, but it's not only that. Elevated levels, they break down the red blood cells. We get disease, tissue damage, heart, liver, kidneys, skeletal, brain, lungs, and body blood cells. Remember, guys, when people are having issues with tissue perfusion, what is the first organ system that we're going to see changes in?
They're going to have mental status changes.
Level of consciousness, because the brain doesn't store oxygen, does it? So it depends on that. So the thing is, the first thing, it's that patient that, they said they're just not acting right. Well, what do you mean they're not acting? They look fine to me. And sometimes that mental status change is hard because what are our old people great at? They're great at memorizing what day of the week it is. Have you ever had that? You walk in, I walk into people's rooms and they go, hi, and they go, my name is Jim. It's Wednesday, it's October 17th, and I'm at Iowa Methodist Hospital. I was just coming in to say hi. So they say if you want to do that mental status, ask things, like it's July in Iowa. You going to wear a winter coat? And so it's just trying to get away from those plain Jane questions because they can memorize them. Because everybody and their mother comes in and asks them the same questions. So in states of global hypoperfusion or shock, lactate production increases. Remember, when we don't have the oxygen, we're going to switch Krebs, we're going to get the production of, we get pyruvate, and then we get the lactic acid. So as a result, we're going to have some increased oxygen consumption, insulin, and acidosis. So what do we have to do? Biggest thing, early recognition. We've got to recognize it. But God, how do we recognize it? Do we want to say, oh, let's give everybody, one thing about our society now has become this, go to the doctor, get an antibiotic, and I'm healthy. How many times have you felt sick and you go, all I need is just that one little magic thing, and then, or the other one is, my nephew's like, oh, I got some of these antibiotics at home, and I got a cut. You think I could start? I go, why do you have antibiotics? Well, they put me on and I felt better, so I stopped. So how many people don't, once they feel better, they stop? And how many times I miss, I can tell you, I'm a bad little sometimes medication person. Fluid resuscitation, antimicrobial therapy, and then find the source. Unless your patient comes in, like a lot of times, like the COPD that comes in known to you in the community, you can say community-acquired pneumonia if they have a cancer background, maybe it's a neutropenic fever. But a lot of our patients come in unknown source until we can figure out what's going on with them. Like we'll come in and we'll do cultures and we may never get a growth out of them. We recently had a young gentleman, he was in his late 20s and he had been traveling, had been out to Colorado and just came home and came to the hospital because he just wasn't feeling well. And his temp was like 41 degrees, and we couldn't get it down. We had him on the Arctic sun, we had him packed in ice, we couldn't get it down, and lo and behold, he goes on and he just went through this cascade and he ended up on ECMO for us. And so what happened is they eventually, they couldn't find an organism. They knew he had this liver abscess and they're like, what the heck, where'd this come from? And so then they're thinking, did he go swimming somewhere? Was he, did he swallow, eat something or anything? Well, all of a sudden, one of the cultures later on showed, like, it wasn't even that it said, this is this organism. It showed one of the byproducts of a bacteria. And so basically, they were able to go back and found out he had oral. He had bad teeth. And they had pulled some teeth. So, and normally they said, when the infectious disease docs were saying when that organism goes, it doesn't usually result in a liver abscess. And so that's why it kind of threw him off, with it. And then, they figured, okay, this is it, and this is what he had. But it took them almost they were in probably about a good 10 days before they were able to figure out what organism it was. And, he recovered, probably his age was it helped him there. But so screening sepsis, they recommend that hospitals have some kind of system in place to improve their performance for sepsis, like screening, sepsis screen for ill, high-risk patients. Who's high risk, guys? Pretty much everybody, because what do we do when they come to see us? We poke and prod them, don't we? We penetrate the one thing that we know is our biggest protection. And then the other thing is, we talked about people with a lot of comorbidities and a lot of health problems. They're probably having a lot of things done. A lot of people on dialysis with fistulas that are being accessed. A lot of people with ports. Kids, chronic illnesses. Kids that like to cut. So, do you guys have a screen?
Yes.
So screen. Is your screen the 2 questions, or is it still?
The 2 questions.
Yes, well, yeah. I have an issue with that,
No,
as we do.
Isn't it this? It's this.
It's the SIRS.
Oh, yours is SIRS?
Yeah.
I thought
It
was the 2
starts-
questions.
Okay. So, yeah, because we've gone to 2, I'll show you ours. But basically, early recognition. Everybody's like, oh, it's another checkpoint. Okay, but if you got on your plane, pilot has to do his checklist. And if he got on the plane and said, oh, it's another checklist, would you want to get on the plane? So it's like a checklist. What this screen does is it helps to bring items together so that we won't overlook things that we may not pull together. Because it's going to ask those questions, it's going to bring in the different signs, and it's actually going to help with some critical thinking out there, like to make people stop and say, even if this isn't sepsis, why is my patient doing this? I need to investigate. This is what our screen has now become. They go, 1 question. Do you suspect in any way that this patient has an infection based on your judgment? Okay, so patient walks through. I have a great case study. Patient comes into the ED. Fatigue and weakness for 4 months. Comes in, treats, do their cultures, everything, send them home. Comes back about 2 weeks later. Gets admitted this time because they say, oh, he's dehydrated, blood pressure low. As they admit him, they find a scrotal abscess. So they debride that, do what they have to do. And then this gentleman, he's kind of like, some days he'll let them pack it, some days he just doesn't want it touched or changed. So anyway, he has this scrotal abscess, he goes home. He gets that removed, there's still an open incision, he goes home. About 2 weeks later, he comes in, again, fatigue and weakness for 4 months. They're like, oh, and he's dehydrated. Okay, dehydration is one of those things that sneaks up, because think about it, guys, if, to become dehydrated, you literally are not getting near any, how many people get thirsty and go, oh my God, I need that glass of water? And we will do anything sometimes to get that drink. But, somebody that can't get up, it's more than maybe a fatigue problem. So anyway, proceeds, he gets sent home. They do cultures, his culture comes back positive, and I don't know, we're not sure, but the pharmacist that's how they did, the pharmacist called and they believed that it was a contamination. Because it was only in one, so it goes, he stays home. Comes back a week later. As he's coming in with squad, his blood pressure's in the 70s. Heart rate's only to like 80, 90, but he takes a beta blocker. And he comes in, and we're treating him for dehydration. He gets put out to the regular floor. He's put out to a regular floor. He goes out. Nobody has identified this urine, nobody has identified this abscess site. But he goes out, they gave him like a liter of fluid in the ED, and so what did it do? He got better. But then what did he do? It was that magic carpet ride in the elevator, you know. All of a sudden everything started going the other way. His urine had come, they did a urine screen, so it had come back, and he had nitrate and leukocytic esterase. So they said, okay, he's probably got a UTI, so that's where they're kind of maybe going. They had done his labs, his WBC was only like, it was 10.42. His RBC was 2.8, hemoglobin 9.5. He did have bands on his WBC. It was they were 2.6, so okay, he's getting some bands there. He had, his sodium was 131, potassium 3.8. His chloride, I smell fire. His chloride was 102, CO2 12. BUN was 45, creatinine was 3.7. His alkaline phosphate was 172, AST was 59, his ion gap was 21. And so he goes, they never did a lactic on him. So he goes out, goes to the floor, and he remains on the floor for about 14 hours because he got out there and his vitals were down, everything was down, and they kept calling and they said, you know, he's low pressures, he's this, we think he needs to go, he's septic, you know, and it's like, yeah, we know he's septic. We started an antibiotic for his UTI, and so, you know, just give him some fluid. So then all of a sudden becomes the MET call, the rapid response. Go over, look at this gentleman and say he needs to go now. So he goes, he's modeled, by the time he gets to the critical care, he's modeled to the nipples. He gets immediately intubated, and then within an hour, they're going to start him on CRRT. They're getting lines in him. First time that scrotal incision was identified was in the critical care, about 32 hours after he was admitted, when he came in the ED. And he proceeded, and within 12 hours, he passed away. Could his outcome have been different? We don't know. But could it have been, if he was that sick, could it have been maybe he could have had time with his family to say goodbye, you know, and they could have visited, or, you know, who knows. The thing was that, you know, once you looked at that thing, that was an open area. That was like, hey, I'm here, this is going on. And it was, you know, he kept getting pushed that he was dehydrated and he had a history of alcoholism. And so that was kind of getting put on top that, you know, he's probably going through drinking binges and not hydrating, and he just can't get out of bed. So that's why he's laying around. So everybody was kind of adding their own little story to him. But one thing that we missed was he had multiple visits. And why was he fatigued? And he had multiple visits, and, you know, even like in Epic, there's the sidebar where it'll bring up those problems, and it was like, we weren't focusing, what we were focusing on, he's a frequent flyer, he comes in frequently. He was here last time, and they told me about him. And it's like, you know, you're doing, like I give you a bedside report, and I say, oh God, she's annoying, she's agitated and restless. So you go in and she's getting worse, but we kind of, sometimes we get clouded vision. And so that, you know, that was what happened. So they did this. So when this gentleman came in, his screen every time was no for the infection. And it says, do anyway, well, he was modeled when he came in. He had a low pressure, a simple no, and then this question doesn't come in. If you answer no to this question doesn't come in. So they've tried to make it easier to have a quick question, but they've taken away some of the things that are gonna help some of our newer nurses to identify patients. And so, if this question had come in, like even his mental status, he was talking to him, but you go in and you'd say, hey Kim, and he'd talk to you later, and then he was gone, he was out again, right in the middle of the conversation. Is there a wood burning stove? It smells good down here. Appropriate first step is, what's that? I smell wood burning.
I was just backwards. There's a fire outside.
Oh,
like
okay.
Somewhere outside, not here.
Okay, good. I
Definitely
just,
pretty.
that's my chemist coming out in me, that's my smell. But at first, screening and identification, and then we should continue to use signs and symptoms of the infection, promote early identification, and then quick SOFA. But the question is, what are some of the signs and symptoms? You know, these people, it depends on how they're gonna present. How they present is gonna depend on what organism, how it got into them. But they're saying that we have to have that low threshold, so meaning that we're not gonna sit there and wait. We're gonna be highly suspicious. Be highly suspicious and get some early recognition of sepsis, because every hour we delay antibiotics, it increases their mortality by 7 to 8%. And we already know if someone comes in and they have pulmonary issues, their kidneys are already in, like look at this guy. He definitely had, because he was on oxygen, he normally didn't, he was requiring oxygen, his kidneys were showing, and he had liver issues. He already had 3 organs down, he was already 60%. If you go, if they're saying about 20% for each time. So he was already in trouble before we even touched him. So, some of the specific concerns: pneumonia, urinary tract infections, meningitis. In the children, I started learning about the neonate world and the pediatric world. That is the highest, they have a very high suspicion for any kid that comes in with a fever, that it could be meningitis. They'll look for that because, especially in the neonate population. Skin infections. Another case study, they said lady came in with a little cellulitis on her arm, and she was another one that ended up passing. Because it wasn't bothering her, she didn't really point it out. I remember when we would sit there and you'd get somebody, like I had a patient one day, this is a while ago, and I had a patient and she was coming in, she had her hip replaced. And I remember they called me, and the nurse was actually was a float nurse that had brought the patient up to me. And they said that she had gone out to the doctor because she was having such increased pain, and he started giving her, increased her oxy, and then also put her on, she had Ativan, and then put her on Xanax because she had a history of anxiety. So the reason she came to the hospital, her family came, was an unintentional overdose because her level of consciousness went down. So they come in and they said her WBCs are like 20,000. Well, we did an x-ray, it's fine. And I'm like, okay. So all of a sudden, at that time, Dr. Melahorris was a resident, and we're sitting there, and I said, can you help me get her sweats off? Because this woman wouldn't I touched her arm, and she was like, ah! I'm like, okay, can we get her sweats off? And all of a sudden, we get her sweats off. So everybody seen Duoderm? You know how it's the brown color? I go, and I go, holy... You can just imagine what I said. And I pull, and there's this strip, and I go, why would anybody put Duoderm on an incision? And the incision is, here's her leg, and it's out like this. Bright red. Well, that wasn't Duoderm, that was Telfa gauze. And the drainage that was coming out of her incision was the color of Duoderm. So she immediately went to surgery. But it was, we had to get ortho in first. Infectious disease came and said, she needs to go, you need to get in there. But, she had an infection. She had surgery, but never had looked at that site. And she could not tell them that's what was bothering her, because her family kept saying, she got all these drugs yesterday, and she was really in a lot of pain, and she took them. Some of the common generalized symptoms: fevers, rigors, chills, confusion, anxiety, fatigue, malaise, muscle aches, dyspnea, nausea, vomiting, decreased urination. Localized symptoms: they may have a headache, they may have neck pain, a cough if they have issues with their lungs. Elderly people, we got to be really, because they might not have the same immune. The little babies, their immune. In little children, as we say, they have the cell count, but their immune system just doesn't have a function. Anybody watched kids, about 3-year-olds, play soccer? Anybody watched a 3-year-old soccer game? And they're all standing there, they put them in their places, and then once the ball hits the ground, what happens? They all converge on the ball. They're beating up their own team members because they know they need to get that ball into the net. My little nephew, when he was 3, he just picked it up, walked through the crowd, walked on the other side, dropped it down, and kicked it in the net. He needed to get the goal. So they have a function, but they have the right number and they have a function, but they don't know what their function is. They just are all determined to get out there. Some of the gastrointestinal, abdominal distension, bowel sounds decrease. It's basically anything. They can have discharge, they can have wounds, ulcerations. They can say they were recently in for a hospital. Another question is, have you had recent antibiotics? What's recent? 3 months ago? That's that's the deadline we do? Is that the right time? We don't know. Not sure. It's like, that's just kind of to give us like a point. Where do you say what's recent? So they jumped on 3 months, but is that the right? We don't know. Diarrhea. There's joint pain, knee pain. As you're going, cough, shortness of breath. We can just go on, and then, and yes, okay, the post-surgical. But one thing that has gotten in the post-surgical is, they had a patient and they called within like 6 hours of surgery. The patient was looking septic, and the resident at first said, they can't be septic, they just had surgery. We have to wait. Well, the person had perfed their bowel. And most of the time, I don't know, perf bowels it's not usually the first thing. It doesn't usually come up and we have them in OR right away. Usually they probably had trouble and they probably have some stool in their thing, but it was like finally she just said, I'm going around you because this patient's in trouble. But it was just trying to get that thought that, why couldn't it be? The goal of your assessment findings is to recognize sepsis in the earliest. So you guys, as the ER nurses, ER nurses, first providers, the ER docs, first providers, ask the question, have they had a recent diagnosis or clinical evidence suggesting a new infection? The question, even simpler, one of the docs that used to do our sepsis with us was, just ask yourself, could this be sepsis? So presentation varies, I talked about, and high suspicion of suspicion level of suspicion, early recognition. These are some abnormal findings. Wow, doesn't really point. Blood pressure changes, temp change. Remember, patients that come in hypothermic, they're in trouble. Because what do we all know? If we have a functioning immune system, and we get something and our bodies begin to fight, we're going to generate heat. Your elderly patients that come in, or your infants, little children usually come in hypothermic. They're in trouble. In children, hypotension's a late sign. It's a late sign. Kids will get fluid, but they'll probably get inotropic therapy faster than an adult will. Decreased urine output. How many people really know? They might, how much they're really peeing. They might know that, like, I haven't peed they might know it by the number of times, but they're probably not going to be able to tell you. Unless they say, like, I sit on the toilet for 3 minutes to pee, and so I know how much, you know, but I remember I did home care once, and I had a lady that took Lasix, and they just put a plastic garbage bag on her chair, and she would just continuously pee in the garbage bag. So she just didn't have, because she couldn't walk well. I'm like, oh, yeah, that's not good. The other thing is abnormal increase or decrease in what WBCs. You know, you can also, remember the shift to the left, you have normal WBCs, but you're seeing bands. When we do a differential, the only time bands will show up is if they're there. Otherwise, they won't even list it on the list. They won't put it as 0. They switched around and they did that. And at one point, they were talking about, you know, the bands having a normal WBC and bands greater than 10% is out there in all the sepsis. And at one point, when Unity Point was looking at their sepsis thing, they talked about getting rid of the bands. And we were, you know, nursing's like, you know, that's something, another tool for us. And they said, no, you can manually count the percentages. Yeah, okay, like that's not going to happen. We can't get people to calculate mean arterial pressures, you know, on their own. It's like they're going to count percentages and come up. So anyway, one of the things that happened is we ended up getting a young 40-something-year-old gentleman, had his own business, so you know, for him to go to the hospital, he had to feel really bad. Went in the hospital, he came in, he had some perfusion-ish, looked like bad, they gave him fluid, another one, they thought, you know, he was sick, blah, blah, blah. His WBC count wasn't up, but his bands were 37% when he came in. Never did a lactate, they sent him home, and 12 hours later, like I guess his wife said, 12 hours later he came back in. His wife said he laid on the floor in the living room all night, just like in pain. And the dog just sat next to him howling. That's how the wife got up, because she realized the dog was howling. He came back 12 hours later. His bands at that time were like 69%. And he was, you could see perfusion issues. Ended up, they got their intensivist was there, and they ended up, you know, tubing him, everything, and then transporting him down. And they were trying to figure out, you know, they knew he had like he had a hemorrhagic bladder, and they were thinking, okay, did he rupture, you know, or did he have a UTI that went bad? Did he, you know? And he ended up passing away himself, 42 years old. And you know, and I mean, the poor wife, you know, because he's got an infection, he's got to take these pills, and you know, 12 hours later, she's talking about, because now comes, he was a self-employed, and he was the person that did all the, you know, finances for the house. Something for the symptoms of sepsis. This is a nice little shivering, fever, cold, extreme pain, worst pain ever. You all remember the patient that if they say they're going to die, that's usually not a good sign. Or if they start telling you what their funeral looked like and what kind of flowers they're bringing and how they didn't like their dress, you put them in the coffin, not a good sign. Pale, discolored skin, sleepy. Big one, little kids. What do you usually, when do you know that your child's sick usually? What do they don't eat, right? They're not eating well. They're irritable. So little kids, a lot of times that is their sign, you know, they come in and they're like, well, they're not eating well, or they're just crying, just whining. Short of breath. Another thing that Sepsis Alliance has adopted is their new slogan is sepsis is about time. Little girl that was on America's Got Talent, when she was 4 years old, she had pneumonia, and she sings this song, and she's helping them promote their sepsis. It's about time. And so what they say is, as you go down time, think of time, temperature, either high or low, I, infection, and mental status change, and then E, they say that they're extremely ill. So they're saying just to put those out there as it's time, and as we know, it is a time issue with perfusion. There's our SIRS criteria. So this just is, it's not saying, hey, they have an infection, but could they? We need to figure out what's going on if we're seeing this. And like I said, the young and the elderly, you know, sometimes your elderly, you know, their normal body temperature can be 35.7 because they don't have sub-Q fat, they don't, you know, and it's like, and so all of a sudden they're just hitting that, you know, they're hitting 30, 37, 38, and they're probably already at a temperature for them. This is that sequential organ failure assessment that I talked about. And as you can see, most of this is, you know, getting some labs and different. We do not use this. It is not built. I think it's built in Epic, but we don't use it. It's not. They haven't pushed it out there. It's kind of like the Apache score. You know, you can use that. That's going to give you your prediction of your mortality in the critical care. Same thing with the SOFA. This is the quick SOFA. Predicts mortality better than SIRS, but it's not as sensitive. So use them both because the quick SOFA brings in this altered mental status. That's how maybe most people come in. You know, we used to, one of the big questions you ask is, have you had a temperature? And because a lot of times people may not have a fever because what have they taken before they may have taken Tylenol. So one of the questions is if they don't, you know, and they're feeling like this and say, have you been taking Tylenol for? It's just kind of rewording the way we're going to ask the questions. And that is side by side. Oh, yay. So what Society of Surviving Sepsis came out and said, we got time limits, guys. Now there's an hour bundle, a 3-hour bundle, and a 6-hour bundle. When they first came out, we had up to 6 hours to turn someone around. And by 24 hours, we could have them fixed. We're now down to, they're saying the new 1-hour bundle is something that they're really, you know, people are starting to look at. Do we put this to a 1 hour? Saying blood cultures, lactate, all your antibiotics are given in that 1 hour. Fluid resuscitation, that's not much time. Because as we said, if they're coming in, where's time zero? Time zero is the moment that you identify sepsis. But this person could be septic and could have been septic at home for how many days, you know, for how many hours before they enter. So they're already could behind that 1 hour mark right there. The 6-hour bundle, you complete, and this is where your patient, you know, if your patient responds to the initial treatments, could they? Yeah, they could stay. You could have stopped it. You're just going to keep screening them. One of the things was when we first started our screen, people stopped screening because they knew they had sepsis. But remember, the screen is not only to identify sepsis, but it is to also identify if our treatments are working. To help us realize, did our fluid resuscitation, are they going backwards the other way? Are they coming back? The 6-hour bundle, you should have your lactate rechecked, especially if it was greater than the 2. You need to have it rechecked within probably about 4 hours. So that's another thing is sometimes, you have an order set for sepsis? Mm-hmm. Sometimes, do people always use it? Okay, good, you guys are good. I like that. But a lot of times, you know, if they're not using it, one of the things, you know, if you're transferring a patient out of the ED and you work them up for sepsis, making sure that that nurse that's getting that patient is aware that you're going to need to be rechecking their lactic and how, and you know, that you got to recheck that. And that's an important lab for them to know. Are things going the right way? Because especially if it was greater than 2, we want to know. We want it less than 2, especially at that 4-hour mark. And if it's not, then we need to do a little more work here. And then here's your initial resuscitation. So, there's a, but they're medical emergencies. Fluid resuscitation for the adult is 30 mils per kilogram. For the pediatric, it's 20 mils per kilogram. For the neonate, 10 mils per kilogram. The big thing about now neonate, they have sepsis stuff and they talk about screening. It's that pediatric child, because most sepsis screens, when you look at the surviving sepsis, that's all deals with adults. Hopefully the next ones that come out will have some peds in it, but it's that when they're no longer a neonate to 16 years of age, that there's not a lot of information on out there. So some people develop their, they use their adult screening and just screen everybody. But,
What about the 12-year-old who's adult size? Do you do the 20 or do you do the 30?
it really depends on him. You start your 20s, you can see what he does and if he needs more after that point. Because as long as they're gonna be responsive to fluid, you should give fluid. It's just that point where, and now we have at least something that is showing us we can do something to do responsiveness, whereas we used to just do it until they gained a couple of pounds. So fluid resuscitation, basically the hypoperfusion, this should be given within the first 3 hours, and they're saying, when are you gonna give this? If the patient is having any sign of organ dysfunction and/or they have their mean is less than 65, or their lactate is greater than 2, and they're showing signs of hypoperfusion, give them fluid. Then when you after you get that initial fluid resuscitation, additional fluids would be guided by frequent hemodynamic status. You can do your CVPs. Do you guys do CVPs? No? What's that? Okay, yes, okay, I had to remember where I was. I was out at Grinnell yesterday and I couldn't remember, or G's, too many G's in the thing. But anyway, yeah, so you're gonna have to look at blood pressure, maybe how their mental status is, right? Those are all hemodynamic. What's their perfusion? One thing too to teach people is, they're getting someone and you're suspecting sepsis, please tell them, look at their body, look at their skin, because one of the things is that perfusion.